Everybody, my name is Max. I'm an intensivist from Washington, D.C., and we're going to talk about antidysrhythmics in the intensive care unit today. I have no financial disclosures. So when I think of antidysrhythmics, I think of this really important turning point in The Empire Strikes Back. It's where the ion cannon is referenced on the planet Hoth. So in the ICU, when it comes to antidysrhythmics, when exactly is it appropriate to fire the ion cannon? Well, the answer is really for tachydysrhythmias, and by tachydysrhythmias, we mean atrial flutter, atrial fibrillation, or sometimes ventricular tachycardia. And mostly a brief history of antiarrhythmics can be viewed through the lens of sodium channel blockers. And so in 1950 was actually when lidocaine was first observed to perform a chemical cardioversion for a patient with broad complex tachycardia. So follow that up in 1952 with the very famous studies involving squid axons, where we discovered there are three states of the sodium channel, which is, of course, closed, open, and inactive. So fast forward then to 1957, where there was a discovery that lidocaine really doesn't change much during diastole. And then 1971, lidocaine, we discovered, prefers ischemic conditions. Then that is when it was most effective in the lab as an antidysrhythmic. So in the 1970s, a couple more drugs were investigated, and through a series of more rigorous investigations, there was a production by way of a summative classification scheme called the Vaughan Williams classification scheme. And this still confers lots of angst and sorrow for people that are studying for their board exams. Now, the Vaughan Williams classification scheme is a gross oversimplification of antidysrhythmic drugs. So a lot of drugs that are, for example, class 1 have pivotal actions that really have nothing to do with sodium channel blockade. So what happened next was in 1991, there was like this airing of the antidysrhythmic grievances that was prompted by the European Society of Cardiology. And that was called the Sicilian Gambit. And the Sicilian Gambit wanted to transition the thought frame from studying the mechanism of the antidysrhythmic to transitioning to a classification of the mechanism of the arrhythmia. So that was all well and good. And then fast forward 27 years later, in the American Heart Association, what I can only assume was an effort to deploy scientific rigor and completeness, really doubled down on the Vaughan Williams classification scheme and bestowed additional classes and subclassifications. And in this manuscript, oddly enough, they insinuated that the Sicilian Gambit was, quote, intimidating or impractical for regular clinical use. And when I look at their table 1, oddly enough, I kind of think the same thing. And so where this leaves us is really no wonderful way to classify relatively complex drugs. And it is true that there's certainly ongoing quests for the additional holy grail of antiarrhythmics, but this does a little bit feel like an exercise in insanity. And so there's been a lot of work done in the antiarrhythmic space. These are very well-performed trials that looked at antidysrhythmics across many disease states, the most common of which, of course, is acute coronary syndrome. So CAST, of course, looked at PVC suppression, and the results of the trial, both CAST 1 and 2, was that you don't want to inhibit PVCs because you get higher rates of asystole. And then we, in general, as a community, abandoned some of the drugs that were present in a lot of the earlier trials. And this is a complete list of the antidysrhythmic drugs that have been studied rigorously in ICU trials. Exactly. So, again, where this leaves us is both an awkward but also familiar space for intensivists. We rely on our best understandings of physiology when you need to treat an arrhythmia in the ICU, which leads us to our first really important point. We take care of arrhythmogenic substrates. This is the first point that really helps me contextualize when to treat an arrhythmia in the ICU. Patients come in with lots of different metabolic derangements and physiologic needs, and the arrhythmia is often a symptom rather than the disease itself. So by way of example, we can consider the physiological milieu of atrial fibrillation. So lots of extracardiac factors such as hypertension, obesity can predispose patients to atrial fibrillation. And then, of course, there's the inflammation, oxidative stress that is being caused by the patient's underlying disease process. And then, of course, there are the autonomic factors that can cause atrial fibrillation present in disease states such as septic shock. And then, of course, there's the age-old question, is AFib with RVR the symptom or is it the disease? So for patients with septic shock, for example, AFib is really just the symptom. So when do I really need to treat the arrhythmia? Well, it's a contextual question. So it really reduces to a hemodynamic question. Is my patient's cardiac arrhythmia limiting their cardiac output? And the multiplicand that is impacted mostly here is the heart rate. So for example, when the heart rate goes up, ideally your cardiac output should go up. That's true to a degree. So the markers on the x-axis here may vary a fair bit from patient to patient, but this curve holds true at higher heart rates. So when your heart rate goes up, the amount of time spent in diastole goes down and the filling time goes down, and this is when your cardiac output expectedly falls at higher heart rates. This has less to do with heart rate often and more with atrioventricular synchrony when it comes to atrial fibrillation. But there are certain patients with certain diastolic failures that require a higher heart rate because they're unable to augment their stroke volume. So when we need to fix that heart rate, what is it that we need to give them? Well, the second point is that antidysrhythmics are old and a little bit crazy. So the timeline of FDA approvals for antidysrhythmic in recent history really leaves something to be desired. So amiodarone was approved in 1985, then drugs like sotalol, propafenone, and Ibutilide came along, and then most recently in 2009, dronedarone came along. And these are relatively complicated drugs with tremendously complex intracellular mechanisms. And many, if not all of the antidysrhythmics have more than one mechanism of action. And the vast majority of these mechanisms are incompletely understood. And so to bring this back to bedside, there was this international survey that was done to quantify the antidysrhythmic practices of many ICU physicians. And what you can see here, both patients who were hemodynamically stable and then patients who were hemodynamically unstable, is that most patients here received pretty hefty proportions of amiodarone. And we kind of know this to be true, right? For many ICUs, it is a cultural practice to see AFib with RVR, and then in a monosynaptic reflex going nowhere near the cortex, they just get a bolus of amiodarone to address the concern for AFib with RVR. And we kind of know this to be true, and people really love amiodarone, right? It's appropriate for nearly all tachydysrhythmias. It blocks many channels that you both do and don't want blocked, both sodium, potassium, calcium, beta, and alpha. It really blocks it all. So there are also very widely established safety margins here, right? It works for patients with heart failure, patients without heart failure. For many years, there was a concern about giving amiodarone in an infusion, and that concern largely stemmed from a formulation where there was a glycol diluent that was associated with vasodilation. The more updated formulation of the amiodarone infusion does not have the glycol diluent and can be given pretty rapidly. So if we dive into the chemical structure of amiodarone itself, we can predict its toxicities. So the highlighted nitrogen group here is the amine. So the AM in amiodarone stands for amine, which gives it its ability to block sodium channels. Then, of course, there's the very well-known IOD, or the iodine, which can precipitate both hyper and hypothyroid states and can also cause a blue discoloration of the skin. The AR is for the aryl group in the middle to bind the whole molecule together. And the ON is the ketone at the end. And the ketone at the end is what has been implicated in stimulating fibroblast growth. And this is important in disease states such as amiodarone-induced cirrhosis or pulmonary fibrosis from amiodarone. So when you look at the amiodarone or the amine, iodine, aryl, and ketone molecule all together, what you may notice is that it is polar at one end and nonpolar at another. And for those following along at home, when you pull up amiodarone out of a vial, what does it look like to you? Well, to me, it actually looks like a soap, or better known as a detergent. And this detergent property is what leads to amiodarone's probably most feared side effect, which is acute amiodarone hypersensitivity pneumonitis. And so this detergent, or lipophilicity, hides lots of places where there's fat. And so that can be in the liver, in the lungs, but the lungs, again, are what are most concerning. And what you may see for patients with amiodarone hypersensitivity pneumonitis is it shreds up your surfactant. And this is why a very common board question is, what do you see on a bronchoalveolar lavage for patients with acute amio lung? It is lipid-laden macrophages. It's because amiodarone is so lipophilic, it finds the surfactant and just eats it up. And so to make matters even more complicated, amiodarone is involved in many, many drug interactions. Here's, of course, the imminently recognizable CYP3A4. And of course, for patients who are on amiodarone, they're almost never on just amiodarone. They're on medicines like macrolides, calcineurin inhibitors, azoles, antidopaminergics, calcium channel blockers, etc. And so there are several drug interactions which potentially limit its use. And so probably one of the more well-known things about amiodarone is that it lasts a really long time. Namely, its half-life is longer than almost any half-life of a drug that we use in the intensive care unit. So this is the OG 1983 paper that looked at plasma concentrations of amiodarone and its metabolite, desethylamiodarone, after a single 400 milligram IV dose. And so the half-life is anywhere between 60 and 140 days. And that is pretty much several thousand times the length of my attention span. So when you stop the amiodarone drip that was going at, for example, 1 milligram or 0.5 milligrams a minute, you're not really taking the patient off amiodarone for a long time. This brings us to the third important point. Use a short-term drug for a short-term problem. So if your arrhythmia is causing hemodynamic trespass of some variety, use a drug that mirrors the anticipated duration of illness. And an often cited reasonable alternative, of course, is Procainamide. So the half-life of Procainamide is anywhere between 3 and 5 hours. And while most illnesses in the ICU last more than 3 to 5 hours, the kinetics of Procainamide are relatively well-behaved and predictable, and can be extended, of course, with infusions to match duration illness. So Procainamide, you should give about 1 gram over 40 minutes. It can be associated with a little bit of hypotension. And of course, if the patient experiences worse hemodynamic trespass, electricity is always appropriate. Procainamide was examined in the Procameo trial, where it was compared to amiodarone for patients with broad complex tachycardia. And perhaps not surprising to many of us that love Procainamide, Procainamide was associated with better outcomes, such as less rates of death, less cardiac events at 30 days, etc. And so one of the cool things about Procainamide is it acts a little bit like quinidine as a sodium channel blocker. But the way that Procainamide is metabolized is in the liver. It is rapidly acetylated to N-acetylprocainamide, which is a sodium channel blocker. So one of the cool parts about Procainamide is that you can actually use it for patients with Wolff-Parkinson-White syndrome, where Procainamide will block the fast pathway with the sodium channels, and its metabolite, NAPA, will block the AV node, which will then lower chances of ongoing reentry. A less commonly used drug, although is quite frankly one of my favorite magic tricks, is Ibutilide. It's a drug that works very similarly to Procainamide, but it really just works for atrial dysrhythmias. So some patients just need AV synchrony to achieve hemodynamic quiescence. And so for patients who have atrial fib or atrial flutter, you can give a milligram IV, and anywhere between 50 and 80% of the time, patients will revert back to sinus rhythm. One thing to know is that Ibutilide isn't just a sodium channel blocker, it's a potent IKR blocker. And the important part of being an IKR blocker is that you need to know that it prolongs the QT. Pretty much half the drugs we use in the ICU are IKR blockers. Ibutilide, amiodarone, haloperidol, droperidol, all of these medications block IKR, so there's a huge potential for QT prolongation. So where does this leave us? We talked about amiodarone's a little bit scary, Ibutilide is magic, and Procainamide is king. So what does the future hold for us? The future holds probably more reclassification schemes of antidysrhythmics in transitioning to, rather than mechanisms of antiarrhythmic drugs, understanding more about the mechanisms of the arrhythmias themselves. So the points that really help me manage arrhythmias in the ICU is understanding that it's really not the arrhythmia that we're managing, it's the substrate. We take care of arrhythmogenic substrates, and the way that you can treat arrhythmias is often to treat the reason the patient has the arrhythmia. Antidysrhythmics are all old and crazy. The search for the perfect antidysrhythmic is ongoing. And when you're choosing an antidysrhythmic, you want to choose a short-term drug for a short-term problem. I want to thank everybody very much for their attention. I look forward to the rest of the conference.